Next, I would like to provide an overview of dissociative disorders. Professor Christa Cronje is a colleague of mine and a professor of psychiatry at Pretoria University with a postgraduate medical doctorate degree in dissociative disorders. She is also a member of the Board of Directors and the Scientific Committee of the International Society for the Study of Trauma and Dissociation. She has kindly provided me with many of the references I've used in this presentation. Her opening words in the 2015 Textbook of Psychiatry state quite poignantly that in spite of more than 30 years of rigorous modern scientific and medical research, including her own, that dissociative disorders, as the biopsychosocial outcome of complex relational trauma, represent one of the biggest unresolved burning points in present-day psychiatry, where neurobiology and psychology, the hardware and the software of the brain, meet closely. To this, I would like to add the word spiritual, as in bio-psycho-socio-spiritual, in conformance to the latest World Health Organization glossary. What I mean by this is that dissociative disorders represent an extreme biopsychosocio-spiritual crisis. I mean that they affect every aspect of our humanity and force us to question the very nature of our understanding of reality. At the risk of oversimplifying, I would like to start by placing dissociative disorders within a larger framework. One of the founders of modern psychology, William James, described 3 types of mutations in the sense of self: insanity, somnambulism or sleepwalking, and hysteria. Hysteria, in the original psychiatric sense, has remained closely linked with multiple personality disorder and dissociative identity disorder. Building on this basic concept, I would actually propose some modifications, which I hope could be helpful for the purpose of clarity and discussion. Whilst keeping the word insanity to represent a loss of self, or derealization and depersonalization, I would propose intrusions to represent presumed external influences on the psyche, including but not limited to so-called possession states, and imagination to indicate the internal reorganization of the psyche, including the formation of traumatically induced alternative selves or other defensive forms of dissociation. Note that by using the word imagination, I do not mean to say that these are inherently invalid or fictitious, but rather that the premise is that they originate internally rather than externally. Another way to look at it, and more specifically to highlight the foundational reasons for the divergence in therapeutic approaches to these conditions, one could substitute these terms with collapse of the psyche instead of insanity, psychic attachment instead of intrusion, and psychic detachment instead of imagination. Now, insanity or psychic collapse in modern times is almost exclusively treated biologically or medically. Invasions or psychic attachments, depending on the socio-cultural and religious settings, may even be referred to religious or spiritual healers. Imagination or detachment, on the other hand, and all the psychological constructs fall within the province of psychology and psychotherapy. Dissociative disorders have features that could be assigned to each or any of these categories. And given this complexity and the overlapping clinical presentations, the prevailing materialist mindset in science and medicine, and the greater availability of certain health interventions, the better coverage offered by health insurance, and its bias towards biological remedies rather than psychotherapeutic or spiritual ones, and the lack of general awareness of dissociation and the underlying trauma-related etiology. Given all these things, it is not surprising that therapy often defaults to symptom suppression using pharmaceuticals for an indefinite period of time. Unfortunately, when this approach fails to resolve the problem adequately, as is often the case in dissociative disorders, medicine is in the habit of shrugging its shoulders and tacitly or even openly denying the validity of the disorder, extricating itself from further responsibility and deferring further and long-term care to those who may or may not be able to address the underlying issues with greater success. The diagnostic errors and the magnitude of our failure to address the root causes therefore remains obscured, which is also partly the reason why general awareness of the conditions remains so limited. Contrary to popular belief, dissociative disorders are actually surprisingly common. In spite of some overlapping features, they are clinically distinguishable from other mental health disorders. However, coming to grips with these conditions is not only a matter of providing help for these individuals. These disorders ultimately confront our most fundamental understanding of reality and what it means to be human. Because of the relative lack of familiarity with these conditions, I will spend the majority of my time in this section, starting with an empirical overview of dissociative disorders, the reasons why the diagnosis is clinically valid, the reasons why research in this area is often challenging, some relevant socio-spiritual aspects, cost considerations, and treatment options. I would also like to make you aware of a valuable online resource, the International Society for the Study of Trauma and Dissociation. This society has done tremendous work in increasing awareness and generating scientific evidence in support of various trauma-related mental disorders, including dissociative disorders. On the website, they offer several resources for the public, specifically various frequently asked questions, treatment issues, and a search facility to find an accredited therapist. For those who are entirely unfamiliar with this condition, the following video clip offers a very vivid example. It represents the most familiar or classic presentation of dissociative identity disorder, previously known as multiple personality disorder. The switching between the alter personalities in this video is very dramatic, including identities who are legally blind while others are able to see. However, the chief complaint with which individuals with dissociative disorders typically seek out medical and mental health services usually is not because of this. Instead, it is usually for the associated physical, emotional, substance abuse, and post-traumatic symptoms, and not so much for the amnesia, dissociation, and alter personality features which form the basis of the diagnosis. The first part of the video is an extract from the 1976 Hollywood movie called Sybil, which portrays a fictionalized version of the true story of Shirley Ardell Mason.
Born with severe tissue damage, she has lived most of her life in darkness. But her problems run deeper.
Now, how are they related? Are they sisters? Or are you all parts of the same person?
Don't be silly. It can't be that.
No, it can be that. You can all be aspects of the same person. All pieces of Sybil.
No. We're all people. You can see us.
Like the woman in the movie Sybil, she suffers from a condition known as multiple personality disorder. According to psychiatrists, it is a condition often triggered by excessive physical abuse in childhood, where a person subconsciously forms separate personalities to distance themselves from pain and trauma.
The only explanation that I have is that the different parts of me, the different personalities and the different names came about to handle traumatic life events that I otherwise would not have been able to handle or deal with.
Margot, the predominant personality of this interview, was actually born Diana 36 years ago. But Margot has taken over as the core personality. She has been diagnosed as having 68 personalities, all with different names, ages and abilities. Throughout this interview, you will see her change. From a sweet 16-year-old Margot, to Jackie, a tough 21-year-old, to Corey, a 4-year-old who can neither read nor write. And as you will see, not all of these people are blind. For the most part, we will be speaking with Margot, Her vision is 2400. The state of California classifies that as legally blind. Where a person with perfect vision can see something 400 feet away, she must be 20 feet away to see that same image. In simple terms, she can't see her own face in the mirror. Her blindness can't be helped by glasses. It was as a blind girl that she sought treatment at Stanford University outside San Francisco. There she would meet with acclaimed psychotherapist David Spiegel.
First of all, there's no question that there is real damage to her vision. That is, you can see that her eyes do not move conjugately. They don't track together. She has this resting nystagmus of her eyes where they move rapidly back and forth. And that's something that a normal person just can't do. They can't sustain this back and forth eye movement for very long at all. So we know that she had some kind of injury when she was in her mother's uterus or during birth that left her with a rather severe visual handicap.
We watched as Dr. Spiegel gave Margot an eye exam.
Me, for example, what can you make out about me?
Well, my guess would be that there's a person sitting there because of the shape, but other than your speaking, I wouldn't know whether you were a male or female. I'm not sure. Oh, I'm not sure.
Okay, good.
Margot tested legally blind, but then she changed into the 4-year-old Corey.
Someone else needs to call Corey out.
All right, good. Well, why don't we do that now?
Okay.
All right. Corey, I'd like to speak with you if I could, please. Corey? Corey? Hi, Corey. Do you remember me, Corey?
Yeah.
Yeah? Do you know who I am?
Where me be?
Where you be?
Yeah.
I'm Dr. Spiegel, and you're in my office now at Stanford Medical Center.
As we see next, little Corey has good vision.
Could you look at me and describe what you see?
You be the big man.
A big man?
And you not have hair here.
That's right. That's right. What else do you
You
notice?
have eyes to be the color of your shirt.
What color is that?
Be the color of the sky.
The color of the sky? That's right. Okay, can I talk to Margot again, please?
My poor foot.
How are you?
Okay, other than my foot.
What happened? Your foot fall asleep?
Oh, I think she must have been sitting on it.
Oh, it hurts, huh?
Yeah.
How are you feeling?
Okay.
Do you remember what just happened?
No.
Though Margot is unaware of time and content when other personalities surface, she has an understanding of their existence and abilities.
My world is very foggy and very blurry, and their worlds tend to be very clear and concise. All the handwritings differ marginally, as well as voices. So it doesn't seem strange to me that the visual acuity would change as well.
I'm convinced that as she normally functions, she needs a seeing eye dog and she can't see.
Margot's personality shifts can be induced through hypnosis or automatically triggered, sometimes in the middle of a conversation. Still, the whole situation is not easy to comprehend. It's easy to be skeptical.
Some people are skeptics, and maybe they will never accept it, but it's true. It is a real disorder, and there are many others, just like my mom out there, that don't even know it.
Margot's 14-year-old son, Sean, sits by his mother and talks with our producer, Dan Hardy. Sean's love for his mother is a very special story. He's unfazed by any of her 68 personalities.
I could bring Jackie out.
She's a nice person. Jackie, I need to talk to you. Come on out, Jackie. Jackie, I need to talk to you, Jackie. Hi, Jackie.
Hi.
You know what's going on? Have you been watching?
I talked to Meg. She said that there were going to be some people here with a camera.
Yeah. Well, here they are.
Tell me a little bit about yourself.
Well, I'm 21. I consider myself the defender of the tribe.
What color eyes do I have?
Blue.
Definitely blue.
Yeah.
What color shirt?
Kind of a dark green, army green.
Do you know about everybody else that's in the tribe?
No, I don't know everybody.
Everybody is a long list.
Oh, really?
Yeah.
How long is that list?
68 last time I looked.
Who's the guy next to you here?
This is Sean, Diane's son.
How's he?
He's a real cool kid. We wish to thank the following people for their expertise, time, and individual support.
I mean, there's got to be people out there with doubts.
I'm sure there'll be skeptics, and I don't blame them. I can't say that I wouldn't be a skeptic if I were on the other end. All I know is what is real for me and the treatment that I've had and how much that has helped and what a difference that's made in my life.
Corey. Coming out, Corey.
Perhaps the most touching part of this story is Sean's relationship with his mother.
Tell me about the day-to-day life living with this lady to your left.
Well, sometimes it's not this lady on my left. Sometimes it's somebody else. But I get used to it after a while. It's something may change from day to day. Maybe she's not around for a week and somebody else is or a few others are. And it's just like a normal life, basically. I mean, to me, that's the way I picture it. They're not going to hurt you. It's okay. I'm just filming you.
Sean's parents are divorced, and his mother thinks his father should get custody. But Sean doesn't want out. He wants to stay with his mother, no matter what personality she takes on.
I guess my mom's my inspiration, you know. I want to get her back, and I want to see this over with, you know, as soon as possible. But again, this is a long process to, you know, help clear up, and I accept that.
I think he's wonderful, and if I think it wasn't for him, we wouldn't be doing as well as all of us are doing without Sean's aid and assistance at times, and love.
Want a hug?
This is one of the most recent reviews on dissociative identity disorder in the Australian and New Zealand Journal of Psychiatry. It captures the current scientific evidence, particularly over the past 30 years, and summarizes the epidemiological, diagnostic, clinical, and therapeutic research on this disorder. To summarize its conclusion, dissociative identity disorder, in particular, is a complex yet valid disorder. It can be accurately discriminated from other disorders, particularly using structured diagnostic interviews. It is associated with complex developmental and cultural factors, including severe childhood relational trauma. Its prevalence is highest in emergency psychiatric settings, and it affects approximately 1% of the general population. Psychobiological studies are clarifying some of the so-called metacognitive origins of amnesia. And there's support for phase-oriented, empirically guided treatment, to which the condition has proven to be amenable.